Hello, everyone. Thanks for joining me today. I'm Julie Lafford, Executive Director of Alumni Engagement at York University. I want to extend a warm welcome to all of you in the audience, whether this is your first time at Scholars Hub at home or if you've joined us before. Thank you and welcome to this week's event. This webinar is part of our Scholars Hub speaker series and features educational lectures by academics and researchers from York. We're pleased to be able to bring this series online to allow even more alumni to hear from some of the university's leading scholars. Before we begin, I wanted to first start by telling you about York's response to anti-Black racism. Last week, President Lenton issued an update to the York community, reiterating the university's commitment to stand together against anti-Black racism. In the statement, President Lenton wrote, "I want to acknowledge the deep pain and frustration that members of the Black community feel. At York, we are committed to using our role as an institution of higher education to hold society and ourselves accountable to learning, growing, including by listening to and learning from Black voices. I can also share that the university has already started community consultations towards this effort." I urge all of you to visit yorku.ca/rights, as well as yorku.ca/mental health to learn more about campus clubs, organizations, resources, and services that support York's commitment to ensuring that all our community members, including alumni, feel safe and welcome. And tomorrow, June 11th, be sure to join us for a special Scholars Hub edition, Will This Be the One? Reflection, Engagement, and Action Against Anti-Black Racism in Ontario. This is taking place at 11:30 a.m. tomorrow, Thursday, June 11th. It will feature Dr. Uzo Enchua, who is the Provincial Academic Director of Youth Rex, York Research Chair in Youth in Context of Inequity, and Associate Professor at the School of Social Work. She will be joined by Cyril J. Cromwell, Learning and Development Manager at Youth RX, Amina Hagar, and Clementine Olche, Research Assistants at Youth RX and York University undergraduate students. Please do join us for this critical conversation. Although we aren't all in the same location, I would still like to acknowledge that many Indigenous nations have long-standing relationships with the territories upon which York University campuses are located that precede the establishment of the university. York acknowledges its presence on the traditional territory of many Indigenous nations. This territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. So before I introduce our speaker, I would like to take a quick poll, which should be appearing on your screen any moment now. Have you ever attended a York event before today? I'll give everyone then a moment to respond to that. And I do thank you for taking the time to do that. And I'll share the results with you once they are available. It's always great to have so many participants with us for these Scholars Hubs events. So I do have the results now, and it looks like 60% have attended an event before. Welcome back. And 40% have not. Thank you for joining us. This is a really important topic, and I'm sure you feel so too. If you are new to online events and you need help at any time, feel free to click on that Q&A button at the bottom of your screen. Our team is here to help you with any technology issues you might have. The Q&A is the same function that you'll use to ask questions of our speaker at the end of this event. And if you're watching on Facebook, welcome. It's great to see you. Feel free to submit your questions and comments through the Facebook section for the video, sorry, and the team will send them my way so that we get those answered for you. So today's talk is titled Reimagining Long-term Care, Long-term Residential Care in the Time of COVID-19. Featuring Dr. Pat Armstrong, Distinguished Research Professor in Sociology and Fellow of the Royal Society of Canada. Dr. Armstrong was Chair of Women in Healthcare Reform, a group funded for more than a decade by Health Canada, and has served both as Chair of the Department of Sociology at York and Director of the School of Canadian Studies at Carleton University. She is a board member of the Canadian Health Coalition and the Canadian Centre for Policy Alternatives, as well as the principal investigator of a recently completed study titled Reimagining Long-term Residential Care, an International Study of Promising Practices. Welcome, Dr. Armstrong.
Thank you.
It's
and welcome to everyone who's online.
It's a pleasure to have you with us. I'll hand things over to you.
Thank you. I should update that bio because some of it's out of date, but I won't take time to correct it now. Thank you all for being here and for being interested in this topic that finally is getting a great deal of attention in Canada. I started my work in this area actually by looking at women's work. My master's thesis was published as a book called The Double Ghetto, and I then spent years working on research related to women's work. And then our daughter broke her leg, and when we were in the hospital with her as she was in traction, we realized that the hospital was a perfect microcosm of the entire range of women's paid and unpaid work, and that started us on the road to looking at healthcare. And as political economists, that meant we wanted to look at the political and economic context and the pressures that were on delivery of healthcare, as well as what happened within it. And then we moved from hospitals on to home care and finally on to long-term care. My first study of long-term care was in 1988 when I was asked by the Ontario Pay Equity Commission to look at pay equity in that sector. And I have followed that with multiple different kinds of studies since then. But most recently, and what I really want to focus on today, is our Reimagine project. It was called Reimagining Long-term Residential Care, an international study of promising practices. We just wrapped that up in March this year, although many of us are still talking on a daily basis. That interdisciplinary international team is still working very hard on all these issues. We did a wide range of research and used multiple methodologies, but I think that the most important of those was the rapid site switching ethnographies that took us into care homes in all 6 countries. That is Norway, Sweden, Germany, the UK, the US, and Canada. We would take a team of 12 to 14 people into that home. Every team was interdisciplinary, every team was international, and we would observe and interview and reflect together. And it changed the views of all of us, I must say, and was very important in terms of what we are saying now in relation to the future of long-term residential care. Now, in these projects and in others, we started off with a number of assumptions that have been confirmed by the research. So I want to start our conversation today by talking about those assumptions. The first one is that we need nursing homes now and in the future. I'm going to call them nursing homes, even though in Ontario they're called long-term residential care. In other places they're called nursing homes, and it's the most common international terminology, applying to those places that require 24-hour nursing care and receive significant public funding. I would argue that even though we hear a great deal about home care and that we would all rather be in our home, many people cannot be looked after in private homes. As we've been learning through COVID, many people don't have those private homes. Many of those homes are not safe places to be, as we are also learning more about in COVID. Many of them can't accommodate safely the kinds of health requirements that people have who are now in long-term care. And this is skilled work. It's also demanding work, and it can't be provided primarily in the home, even though many of us would like to think that that could be the case. And it's really important to notice too that when we do provide care in the home, it's mostly care unpaid, provided by women, many of whom have never had the kind of training in providing that care than they require to have. I often get told, oh, we're sending care back home. That's simply not true. My grandmother did not have to deal with catheters or oxygen tents or with the kinds of heavy duty demands that are expected of many people in home care today. And people don't get into long-term care in Canada unless their needs are so critical that they can't be provided at home. And we will still need this. So we have to be planning for a future where these places can be places that people actually feel good about going and feel good about having their parents or their grandparents or even their children looked after there. I should have said at the beginning that we have been looking for ideas worth sharing, ideas about how we can treat those who live in, work in, and visit in long-term care can be treated with dignity and respect. So the first assumption, we're going to need these homes now in the future, so we need to fix them. The second one is that the conditions of work are the conditions of care. That these conditions include adequate staffing in terms of numbers, in terms of composition, in terms of training and continuity. These conditions also include pay, benefits, especially paid sick leave, and decent terms of employment, such as hours of work and shift lengths. Many of those have become obvious during this pandemic. The conditions also involve equipment, not just in terms of the personal protective equipment we've heard a lot about recently, but also in terms of things like lifts and adequate showers, adequate carts. But reasonable conditions of care include much more than that. They require some autonomy for those people who provide care. They require the time to provide care and the training that is needed to provide that kind of care, and support for people to work in teams. Union protections, of course, are also important, especially the right to say no to unsafe conditions and to the violence that's far too common in these workplaces. Similarly, the physical structure of the home and its location is important to care. We've heard a lot recently about the 4 bedrooms that seem to surprise a lot of people who haven't been into long-term care, but the physical structures we require go well beyond having more private rooms and more places for people to be able to get out and see the community and connect to the community. And this relates directly to what we've been hearing about, especially in recent days. They have to be workplaces that address systemic discrimination. Now, this is not a complete list of conditions that are necessary for care. We have to take all of them into account in planning for care during and after this pandemic. And if we want to have a labor force, we have to improve these conditions. My third point is that these conditions have to take into account all those who live in, provide paid and unpaid work in, and visit in long-term residential care. It's not only direct nursing that counts, it's also the cleaning, the dietary, and the laundry work. Some of that has become obvious too in recent days, especially if you read the military's reports on homes about places not being properly cleaned, about linen not being available or properly changed, about people not being helped to eat and provided with adequate food. These are all critical to care, and they're particularly important now, but they're often left out of what we think of in terms of care. Indeed, in his Royal Commission report, Romano called these ancillary services and said they could be contracted out. We have seen the negative consequences of that kind of contracting out. I think it's also important in terms of who's there to think about families. Again, we've heard a lot about families and the importance of getting a hug or not being able to provide a hug or be there when someone's dying. But families do way more than that in long-term care. One of the most important things they do is advocate for residents, but they also make up for a lot of the gaps in care by brushing teeth, by helping people eat, by taking them for a walk, and doing a lot of the essential care. Similarly, we have a lot of privately paid companions in long-term residential care. They're one of our biggest indicators of the gaps in care. And we have to think of those workers too when we're talking about reforming the system. And the same is the case with volunteers. A lot of the work in long-term care is done by volunteers. Those people too have been denied access during this pandemic demonstrating how important they've been to making life worth living in long-term care. And should also say, we have exposed a lot of unpaid work done by the paid staff, whether that's shopping for their residents or providing them with the extra things they need, like shampoo or whatever that's not provided in the place. So when we're planning for the future, we have to take all of these people and their training into account. My fourth point is this is skilled, gendered work. I've heard a lot about bringing in people into the community to do this kind of work. And yet at the same time, when you think about the demands of cleaning, for instance, or the demands of helping someone eat who has dementia, who may not have their teeth anymore, who have difficulty swallowing, these are highly skilled jobs. But we've often dismissed those skills because we assume that there's just something any woman can do. And more than 80% of the people who work in long-term care are women, and many of those women, especially in a city like Toronto, are from racialized groups and or have been born outside the country, which also contributes to their precarity and the dismissal of this as incredibly skilled work. Much of long-term residential care is care by women, for women, and that helps dismiss this as unskilled work. And I think we have to change that if we are going to move forward. So we have to recognize and support this demanding and skilled labor. Fifth, context matters. We talk about promising practices rather than best practices because we don't think there's a single right way. We do think that there are ideas worth sharing. We do think that there are some things we know we shouldn't do, like we shouldn't contract out food services. But we need to think about the kinds of principles that can guide action without specifying those in details for any particular place. Because what might work in downtown Toronto will not work in Attawapiskat. So we have to think about learning from ideas from others, but also thinking of our particular context. Excuse me. I don't talk enough when I'm at home, I guess. Sixth, then you'll be happy to know I'm getting to the end because this is my final of my, my assumptions, is that the search for profit does not lead to better care, excuse me, greater efficiency or more choice, nor do many of the practices taken from the private sector. Indeed, such privatization can lead to the reverse of quality care. We have to ensure that public money goes to care rather than to profits, and in a way that allows us to be able to understand where the money is going, because after all, it is our collective money. At the same time, we need standards for all the homes, and we have to make sure those standards are enforced, which requires inspections. So I want to end there, but say that I think it's time for us to get some federal leadership on these issues based on the evidence. I think we have lots of evidence that allows us to act rather quickly. We need, though, to have some leadership across the country that puts that evidence into practice. So now I'm looking forward to hearing about you and from you. Thank you.
Thank you so much, Dr. Armstrong. That was really very interesting, very timely, of course, and I know we have a lot of audience questions, so I am going to get to those right away. First, I have a question from Michael Michelli, who asks, how can we reimagine long-term care in an age of austerity whereby government resources are limited? And it sounds like Michael's looking a little bit down the road for when we're going to be paying back all these, we as a public will be paying back all these bailouts.
I think it's interesting when Tommy Douglas was asked where he was going to get money for the healthcare system that he set up. He had our first public hospital system, of course, was in Saskatchewan. He said, there's only one place I know of to get the money, and that's from the people that have it. I think that, yes, we have to think about where the money's coming from. We've been able to find a lot of money during this crisis. I think we can find money for this kind of care. We also have to think about the cost of not doing this. And the cost is not only the massive rates of deaths we've had in long-term residential care and the sickness amongst those who provide care and not just those who live in these places. We have that cost, but we also have enormous costs in turnover. The highest rates of absences due to illness and injury are in long-term residential care, way higher than in the police force or in any of the other occupations that we think of as dangerous. Those are costs. They cost us all. It's cost us an enormous amount to send the military into these homes. If we'd fixed these things quite a while ago, we would have been in a better position. Oh, excuse me, I don't usually cough like this.
Take your time, please. I have another question from an attendee who didn't provide their name. Is there evidence that not for-profit long-term care is better quality than for-profit? And you started to address this actually in one of your points.
Yes, there's a great deal of evidence. And of course, in all evidence, we're talking about patterns. We're not talking about absolutes. We're not saying all for-profit homes are terrible, that all non-profit ones are wonderful. But there's certainly a pattern that for-profit homes tend to have lower staffing levels that are associated with lower quality. They tend to have more transfers to the hospital. They have more bed ulcers. They have more falls. Yes, we have a great deal of evidence, in my view, that supports the notion that the quality does not follow a pattern of being better in for-profit homes, and that we do have a pattern of the best quality being provided in government-owned homes. There are three kinds of homes in this province and in most provinces in Canada. That is, there are government-run ones in Ontario. Those are primarily run by municipalities. There are not-for-profit ones that are charitable. They may be the Catholic Church or the Italian community. And there are the for-profit ones that are increasingly in Ontario giant corporations like Extendicare and Sienna and Chartwell. And the pattern is clear, I would argue, even though, as I said, it isn't that all municipal homes are fantastic, nor is it that all for-profits are terrible. If I was looking for a home to go into, I'd go into a municipal home. Interesting.
Very interesting. I always sort of thought, this was a problem we could spend money on and get great care. So that's really fascinating.
We should be clear that the homes I'm talking about, the nursing homes and the ones that have been the focus, are all ones that receive significant government funding, and the beds are licensed by the province. We also have what are usually called retirement homes that are for-profit, and that you can pay whatever.
As much as you want.
As much as you want, but you have to remember those places, you pay extra for the care part, the nursing care part, and that they can kick you out, and that they can raise the fees whenever they want, which is not the case, of course, in the nursing homes I'm talking about.
Thanks for that clarification. I have a question from Vandell Morrison. Despite the annual flu season, why are the long-term care homes so ill-equipped to handle epidemics and pandemics? What are they lacking that they need to provide better care?
Staff. I think staff's not the only necessary condition, but it is a necessary condition. You have to have enough people with enough training of the right sort to support that. And those people need to have resources. We heard stories about the limitations on linens and the limitations on adult briefs, on all kinds of things long before this happened. When you have shortages of those kinds of supplies, It's really hard to control infections. When you have shortages of personal protective devices, it's hard to control infections. The most common way of controlling flus has been to keep other people out in terms of these cares. And of course, we have flu vaccines that we provide people with. And there certainly were some precautions connected to the flu and other forms of infections, but this has been of a different sort and much more difficult to tell in terms of symptoms. It's very hard in these homes, the way they're constructed now, to segregate people, those who have COVID from those who don't, especially in the 4-bed units. But we've certainly had 4-bed places with 4 beds in them that have escaped any significant deaths as a result. So it's a combination of factors, including that this was a different kind of flu, but also if you have more part-time people, if you have more agency people, if you have more people coming out, in and out, that the risk is heightened there.
Thank you. You mentioned earlier that your study looked at many different countries, and we do have a question. Is there a model in other countries that we can use?
It's a very interesting question, and I'll partly go back to what I said about promising practices. And we were looking at ideas in all kinds of areas, in staffing, in the physical structure, in the provision of services like food, and looking at the entire range of issues within these homes. Would I say we found the perfect home? No. We were in some homes though that were operating very effectively in many ways in Canada. We certainly saw some in Germany and some in Sweden and some in Norway that were very impressive in terms of their approaches to care, in terms of their staffing, in terms of their teamwork, in terms of their physical structures. But to say that there's one place, if you want to go someplace, this is where you should go. Mm. It's interesting. We had 4 physicians on our team, and 2 of them were with us in our studies of Germany and Norway. And one of them's a former medical director of a long-term care home. And he said he would go to the home in Germany that we visited in a minute. They had a really high staffing level. And part of that high staffing level was because they had a lot of apprentices. This was an apprenticeship system that took more like we think of apprentice plumbers, say, for instance, that you're apprentice for a long time and you work in the same place for quite a while, so that they were familiar. They weren't like a student going in for a week or 2, but they expanded the staffing, and their whole approach to care was based on a notion that you wanted to add life to years rather than years to life, to make life worth living on a daily basis. And that too makes a difference. I think we can go overboard on the notion of safety and avoiding risk, and putting our whole attention on making people safe. So that means we put a lot more people in wheelchairs than we saw in other countries, because we see that as a way of avoiding falls. But what happens, of course, is then you have trouble walking at all. But you need more staff if people are going to be able to walk all the time, to help people walk and to make sure they don't fall.
Thank you. We have so many audience questions, Dr. Armstrong. There's no way, I'm sorry, audience, that we're going to be able to get to all of them, but we are going to carry on for another 10 minutes or so. Oh my gosh. I have one from D. Patterson. Thank you for the great presentation. Is your study available to read? I'd be curious to read about the best practices you found, e.g. how aggressive patients are managed, etc.
We just happen to have a website, and I always forget how you found it.
You know what? We can
perhaps you send it out to everyone afterwards.
absolutely can. No problem at all. We'd be happy to do that.
It's RELTC, like Reimagining Long-Term Care, RELTC dot apps01.yorku.ca. And you'll find that we have about 150 publications, I think. As opposed to a final report, we constantly produce things throughout this project, constantly took our research back to communities, back to residents, back to people who worked in residence, back to the unions who are our partners, back to policymakers to get their response to what they thought we were doing appropriately and what we weren't. So we produced a great deal of material. We have a kind of roundup report that we did because we were going to have a little party in March to mark the end of our project. And you can find that report, which is called Reimagining Long-term Residential Care in the COVID-19 Crisis. You can find it on the Canadian Centre for Policy Alternatives website, as well as on our website. But the other thing you might be particularly interested in is what we call our bookettes. We produce these 4 small books that are available for free in hardcover, but I can't get them out to you right now. But they can be downloaded in electronic form, also from the Canadian Centre for Policy Alternatives. So there's one that's called Promising Practices, one that's called Physical Environments in Long-Term Care, one that's called Negotiating Tensions, and one that is called Exercising Choice. And those 4 books draw on our visits to long-term care homes, our studies of long-term care homes in the 6 countries. So they're full of vignettes or stories about how things work and why we thought those were ideas worth sharing. So you can download those or view them online, download them without cost. We also have a book, we have several books actually, we have 4 books, but one of them you may find particularly interesting is called Wash, Wear, and Care. It's on laundries. And it's always fascinating to me when I raise the issue of laundry with my friends. They say, laundry? Really? You're doing a book on laundry? Whereas if you raise it with anyone who is a resident or a staff member or a family connected to long-term care, they get it immediately. They understand. Because clothes are about dignity and respect, and so is laundry, as well as about health in the way we think of it, clinical health.
That's so interesting. So my colleague Ben has shared your website with all of the guests. So guests, check the chat out. It's there for you to click on, and there's lots to learn, I'm sure. What else do I have here? Molly Roddering asks, governments and much of the public have known for a long time that there are issues with long-term care. Why do you think steps have not been taken before now to fix the root causes of the issue?
I don't know, I'd like to hear your ideas. We certainly had lots of coroner's reports. We've had lots of research studies, and we're certainly not alone in this area. It's interesting, I was asked to do a podcast with a liberal member of the federal government. And he started quoting to me from a 2009 book we had published, saying, isn't this exactly what the military is saying now? And we're certainly not alone. So we do have to ask why this has been invisible. I think it's due to a lot of things. I think it's that we don't want to think about old age. That, I think this every night as I watch television that's telling me how to pretend I don't have any wrinkles and how to look young. So we don't want to think about old age or what happens to any of us in old age. And it's mostly old age people in these homes, although I think it's really important to remember that we have a growing number of younger people in long-term residential care, in part because we've closed all of the other places where they could be. And that's important to think about when we're thinking about long-term care. And I think that it's also because a lot of them are old women. Most of them are old women, and I don't think we value old women very much. I think that the people who work in these places are mainly women, and as I said earlier, especially in big cities, from racialized communities and often immigrant communities. And we don't dismiss this we dismiss this, I should say, rather than as not very important work. So I think that there are a host of reasons, and it's not very sexy, you know. It's interesting to me. We did a study last year for the Ontario Nurses Association. They wanted to do research that would help them promote working in long-term care to RNs and RPNs. We hardly interviewed anyone who made that as their first choice to work. And they don't get much exposure when they're in nursing, taking their nursing education to working in long-term residential care. But we interviewed one young woman in her 30s, I would guess, who had now been working in long-term care for 5 or 6 years. And she said she really resisted going into a home. Her father was urging her that there was a full-time job there and there wasn't a full-time job anywhere else, and she should go into this home. And she said all her friends said, oh, you'll lose all your skills. She said the reverse is true. I used to work in the hospital. I was focused on one particular area. I had one kind of skill. Here I have to use my entire range of skills every day. But I also have an opportunity here to get to know the residents, to get to know the residents' family, to have real relationships with people that I didn't have in the hospital. But we don't think about that when we're thinking about long-term care. I don't know, it's a complicated issue, but I think now we might have the political will. It's interesting to me always when people want to talk about long-term care and are sympathetic and understanding, it's because their grandmother or their mother or somebody they know is in long-term care. Maybe we should get everybody to go and spend the night.
What a great suggestion. I actually have, this is a perfect segue to my next and last question for you. Cynthia Randall asks, what do you see as the best way to begin to make the changes that are needed? A commission or an inquiry, lobbying the government? What do we need to do?
I think all of the above. I mean, I definitely think we need some action now. And it's interesting to me that 3 Liberal members of Parliament have together written a letter saying that they think the federal government should start acting now on the basis of what they know. There could be that short-term strategy at the federal and the provincial level, because of course it's primarily a provincial responsibility, a provincial territorial responsibility, I should say. And we have a lot of information. We know the kinds of initiatives that were taken in BC right at the beginning have really made a difference to say we need people to have full-time jobs working in one place. They need to have decent wages. We could do that tomorrow. We could make those kinds of issues central stage. And we could say you have to have a minimum number of people. Quebec has just announced it's going to hire 10,000 people to work in long-term care. They're going to train them. And they're going to pay them decently, $26 an hour, I understand. I also understand, according to a newspaper article, that 60,000 people have applied. So we could fix that part of it quickly if we wanted to. But I think also we should have a public inquiry with a really strict time period. But then the reason I would argue a public inquiry is that I think that we can't have appointed to such a commission people who have vested, particular kinds of vested interests. I think we all have a vested interest in long-term care, But an inquiry, a public inquiry, would have to be led by a judge and would have to be open and would have to be accessible to all of us in terms of understanding the kinds of information that was provided, and would become the basis for the recommendations. So I don't think we have to choose. I certainly do think we need federal leadership. I certainly think we need some federal legislation. I certainly think it should be backed up with some big bucks, and that it should be conditional. That if you don't meet standards, as we do with the Canada Health Act, and then certainly we did that much more at the beginning, that if you want our money, you have to follow these principles. And I think we could and should do that relatively quickly. Look at how quickly we've moved on all this other stuff.
Yeah, yeah, absolutely. Thank you so much, Dr. Armstrong, for the generosity of your time and your work. Really appreciate you spending this 45 minutes with us. Audience, again, I'm so sorry I didn't get to all your questions. We can't keep Dr. Armstrong here all afternoon.
Well, I'm actually not going anywhere.
None of us are going anywhere, but we did link to that fabulous resource that you've provided. So everyone, hopefully, you can take the time to look at that, and maybe that will help address some of the questions that we didn't get to today. And thank you, audience, for being here with us. Before we leave, I have one last poll for you. The question is, what's your interest in attending Scholars Hub events over the summer months? We're trying to figure out whether we need to pace our lecture series differently as our reality evolves and the weather gets better, which is the great part of our reality evolving right now. Thank you for your time in participating in that poll. I also wanted to mention that you can share this talk with your friends and family. It's going to be posted to our social media channels. So you can follow us on Twitter at York Alumni, and at York Alumni. We're also on Instagram. You can join our LinkedIn group, and you can follow us on Facebook. In both instances, just search York University Alumni. And then in a few days, this lecture will also be posted to YouTube. So feel free to send it and share it freely. Also, if you have any feedback for us about this lecture, about anything else, please feel free to drop us a line, alumni@yorku.ca. And don't forget to join us tomorrow again for a really special edition of Scholars Hub at Home, 11:30 a.m., June 11th. Will this be the one? Reflection, engagement, and action against anti-Black racism in Ontario. I really, really hope that you will take the time to be there with us. Thank you once again, and I hope you all stay safe and well.
Thank you.